University College Hospital, London, sometime in the early 1840s. The operating theatre is full. Medical students lean over iron railings in the gallery above, pocket watches in hand. The air smells of sawdust and old blood. There is no anaesthetic. There is no silence. A man enters, 6'2", bottle green coat, Wellington boots. He moves through the room the way a duellist approaches the line. In his hand, a long straight knife, his own design. He looks up at the gallery. "Time me, gentlemen, time me." The patient is pinned to a wooden bench by 3 assistants. He is conscious. He will be for the entire procedure. Robert Liston grips the leg. The knife moves. 28 seconds later, the limb is on the floor. But today, the knife has cut more than the leg. This is his case file. Before 1846, surgery had one rule: be fast or the patient dies. There was no reliable way to render a person unconscious. Patients were given alcohol, opium, or nothing at all. They were held down. They screamed. They fought. The longer the surgeon took, the more blood was lost, the deeper the shock, and the greater the chance the body would simply stop. Speed was not showmanship. It was the primary survival strategy. Surgeons were ranked by the clock. A competent surgeon could remove a leg in 3 minutes. A good one could do it in 2. The fastest surgeon in Britain could do it in under 30 seconds. His name was Robert Liston, and he was the best in London, by a margin that made other surgeons refuse to operate in the same theatre. Liston was born in 1794 in Ecclesmashan, a village in West Lothian, Scotland. His father was a clergyman. By 14, he was enrolled at Edinburgh Medical School. By 16, he was assisting the anatomist John Barclay in dissections. He had large hands, unusual height, and a disposition that did not bend. He was dismissed from the Royal Infirmary of Edinburgh in 1822 for confronting a senior surgeon he believed had mistreated a patient. He was not reinstated for 5 years. When he returned, he built a reputation that no one in Scotland could match. His amputation technique used a straight-bladed knife, later called the Liston knife, that cut from the inside out, creating muscle flaps, faster and with less pain than the standard curved blade. He designed his own bone forceps to clean the stump after sawing. Both instruments would become standard issue in US Army surgical kits during the Civil War, 2 decades after his death. In 1835, he moved to London and was appointed the first professor of clinical surgery at University College Hospital. His operating theatre became the most attended in the city. Students packed the galleries. Visiting surgeons came to watch. Before every procedure, Liston raised his knife and said the same words: "Time me, gentlemen." His mortality rate for amputations was approximately 1 in 10. The average for a London surgeon at the time was closer to 1 in 4. He was not just fast, he was precise, most of the time. The operation that would define his legacy in popular culture took place on an ordinary day in the surgical theatre. The account comes from the surgeon and medical historian Richard Gordon, who documented it in his 1983 book, Great Medical Disasters. The patient was a man requiring a leg amputation above the knee. He was carried into the theatre and placed on the wooden operating table. No padding, no sheets. The floor beneath had been covered with sawdust to absorb what was coming. 3 surgical assistants, known as dressers, took their positions. 2 to hold the patient's torso, 1 to hold the leg steady. Their job was to keep the limb still while Liston cut. They were not given gloves. There were no gloves. Spectators crowded around the table. Visiting surgeons, medical students, and members of the public stood within arm's reach of the operating field. There was no barrier between the audience and the patient. There was no concept that one was needed. Liston took his position. He clenched a second knife between his teeth, a common practice, freeing both hands for the work ahead. He gripped at the thigh with his left hand. With his right, he drove the long, straight blade into the flesh and swept outward, cutting the first muscle flap in a single stroke. Then a second thrust, and the lower flap was made. A colleague later described it. 2 or 3 rapid soaring movements, and the upper flap is made. The flap is held back. Another thrust, and the knife comes out in the angle. 2 or 3 more lightning-like movements, and the lower flap is cut. Then, the saw. Liston switched instruments and began cutting through the femur. The assistants bore the weight of the leg. The patient screamed. "This is where it went wrong." The blade moved through the bone and kept going. In the transfer between knife and saw, or in the final strokes of the amputation itself, Liston's blade slashed across the hand of his young assistant, the one holding the leg. 2 or 3 of the assistant's fingers were severed in a single cut. The assistant pulled back. The leg was on the floor. The amputation was complete. Total time, under 2.5 minutes. But the blade had also caught the coattails of a spectator standing too close. The man looked down. He saw the tear in his coat. He saw the blood, not his, but everywhere. He believed the knife had gone through him. The stump was dressed. The patient was carried out. The spectator was helped from the theatre. Nobody stopped at the procedure. Nobody examined the assistant's hand with any urgency. The operation, by every standard of the day, was over. Then the dying began. The patient developed hospital gangrene, a bacterial infection of exposed tissue, caused by organisms that no one in the room knew existed. The wound blackened. The tissue died. Within days, he was dead. This was not unusual. In the 1840s, gangrene killed more surgical patients than the operations themselves. The assistant's severed fingers, exposed to the same unsterilized theatre, the same instruments, the same air, developed the same infection. Gangrene spread through his hand. He died shortly after. The spectator never recovered. According to Gordon's account, the man collapsed in the theatre, convinced the blade had pierced his body. Whether he died from cardiac arrest, brought on by fright, from shock, or from some other cause, the records do not specify. What they specify is that he died. 3 people entered that theatre for one operation. None of them survived it. A 300% mortality rate. No other recorded surgery in history has matched it. The 300% mortality case is not a story about a reckless surgeon. It is a story about a system that made recklessness inevitable. In the 1830s and 1840s, surgeons operated in frock coats stiffened with dried blood and pus. The stiffer the coat, the more experienced the surgeon was presumed to be. Sir Frederick Trevis, writing later in the century, described the standard. There was no object in being clean. Indeed, cleanliness was out of place. It was considered to be finicking and affected. Instruments were not sterilized between patients. Operating theatres were open to crowds. Surgical assistants held the patient's limb bare-handed. The concept of germ theory, the understanding that bacteria cause infection, would not be demonstrated by Louis Pasteur until 1861. Joseph Lister's antiseptic technique would not be published until 1867. In Liston's theatre, pus was called laudable, a sign that the body was healing. Within this system, speed was rational. A faster operation meant less time for tissue to be exposed. Less exposure meant less infection, though nobody understood why. Liston's speed saved more patients than it killed. His 1 in 10 mortality rate was exceptional. But the system had no safety margin. The knife that saved 9 patients out of 10 could, on a single stroke, kill 3 people at once, because no one in the room believed that a blade needed to be clean, that a spectator needed to stand back, or that an assistant's wound required the same urgency as the patient's. The 300% mortality case was not an aberration. It was the system operating at its logical extreme. On the 21st of December, 1846, Robert Liston walked into the same operating theatre at University College Hospital. The galleries were full again. The patient was Frederick Churchill, a butler with a diseased leg. This time, there was a difference. A medical student named William Squire administered a new substance, diethyl ether, through a glass inhaler. Churchill inhaled. His body went still. His eyes closed. Liston amputated the leg in 25 seconds. Churchill woke. He looked at the stump and asked, "When are you going to begin?" Liston turned to the gallery. "This Yankee dodge," he said, "beats mesmerism hollow." It was the first public surgery under modern anaesthesia in Europe. The same surgeon who had represented the peak of speed-based surgery had just made speed irrelevant. 2 of the students watching that day would go on to change surgery permanently. James Simpson pioneered chloroform anaesthesia. Joseph Lister pioneered antiseptic technique. Robert Liston died 11 months later, on December the 7th, 1847, of a ruptured aortic aneurysm. He was 53. For 30 years, the fastest knife in London saved more lives than any surgeon in Britain. The one thing he could not outrun was the century he operated in. One question for the comments. If surgery required speed to survive, what other medical practices were shaped by the tools that did not yet exist? The next case on this channel involves a disease that paralyzed an entire generation, then disappeared without explanation, and no one has seen it since. This is the sealed ward